attending this webinar. Sorry. Thank you all so much for attending this webinar today, hosted by the NNLM RML Region 2. This is the last webinar in a three-part series on evidence-based practice. Today, we will focus on critical appraisal and application of the evidence. I'm Emily Brennan, a research and education informationist at the Medical University of South Carolina Libraries in Charleston.
And I'm Amanda Davis, the manager of the Value Institute at MUSC Health in Charleston.
As part of the MUSC Libraries, I work in the Research and Education Services Department. I'm the liaison to the College of Medicine, residents and fellows, and hospital nurses, providing educational, research, and clinical support for students, staff, and faculty. I'm also a member of the Value Institute.
Thanks, Emily. I'm really happy to have you on our team. The Value Institute falls under MUSC Health's Population Health Department and lives within quality at the system level. We provide EVP education to frontline staff and evidence synthesis services, as well as facilitate the development of hospital guidelines and clinical pathways with interprofessional teams across the health system.
After completing this webinar, we hope that you will be able to describe study designs and the hierarchy of evidence. Select articles in a systematic way that ensures objectivity. Describe the hierarchy of evidence, study designs, and their potential biases. And lastly, describe the importance of statistics in understanding research findings. During the previous webinars, we focused on steps 1 and 2 of the evidence-based practice process. Step 1 is to formulate the clinical question using the PICO framework. And step 2 is to acquire evidence by searching databases and other resources. Today, we will focus on steps 3 through 5. Amanda will spend most of the session discussing study design, critical appraisal, and descriptive and inferential statistics. Then she will briefly cover applying the evidence to practice, as well as assessing the results. So I'm going to pass it to Amanda for the rest of the webinar.
Thanks, Emily. I wanted to quickly recenter our discussion around the clinical scenario that we've discussed in the last 2 webinars related to burnout in hospital nurses and the use of mindfulness techniques to combat and treat burnout. As Emily has mentioned in our last 2 webinars, the PICO elements for our scenario are hospital nurses, mindfulness, and burnout. So as you can see, there isn't really a comparison for this scenario, so we left that section blank. We've also taken our PICO elements and applied the clinical question you see here. In hospital nurses, what is the effect of mindfulness on burnout? We've also framed this as a therapy question because it acknowledges that many hospital nurses are actively experiencing burnout and that mindfulness will be used as a therapy for treatment. As you can see here, the best study design for this type of question is an RCT. As we get started, I just wanted to center us on why evidence-based practice is so important. While it takes time to engage in this process, it also saves time in the end by preventing individual healthcare providers and entire healthcare systems from reinventing the wheel. So how do we decide what's most relevant? This is an important step in the process because learning to systematically select articles with the best fit for supporting evidence-based decision-making is a key element of critical appraisal. How do you decide what to keep in your collection and what to throw in the proverbial trash can? Article selection should be a systematic process that starts with identifying the appropriate studies for your PICO question. Based on the discussion during the last webinar, we can quickly confirm that we addressed the first step in article selection because our search terms are consistent with our PICO question. This is the first step of the process. Next, We use our question type to confirm the study designs we want to target with our search. As noted previously, our focus is on RCTs. When we look back at our evidence pyramid, we see that RCTs are at the top of primary studies, but that meta-analyses, systematic reviews, and clinical practice guidelines provide even higher levels of evidence if they're available. An optimal result for critical appraisal would be to include studies at or above RCTs on the evidence pyramid in relationship to our clinical scenario. However, there are times where searching will not identify pertinent RCTs. This is when we work down the pyramid, one study type at a time, in order to provide the strongest level of evidence available on a topic. I remind our EBP students regularly that they are not responsible for what level of evidence is available on their topic. They are just responsible for being thorough and objective in their search for what is available. There are multiple steps to the process of identifying study design. First, we confirmed that with a therapy question, the initial focus is on RCTs and above on the evidence pyramid. Second, we use this information to apply filters in PubMed. So we did some of this last webinar. And as you can see, when we looked at that, applying those filters in PubMed, like Emily walked us through, when we apply those filters, we have 26 results. In looking at those results, we see that many of the articles in our collection are systematic reviews. Because of the length of the systematic review process from search through publication, it's important to add an additional filter of published in the last 5 years. That ensures that the literature that we're looking at is both highest on the pyramid, but also newest from the perspective of what studies were included in that systematic review. As you can see in this screenshot, when we apply the additional filter, we now have 16 results. We put all 16 articles from this collection onto our PubMed clipboard so that we can then move to the next step of our article selection process. With a final collection of 16 articles that are all RCTs, systematic reviews, and meta-analyses published in the last 5 years, we can move on to the next step in the article selection process, which is considering inclusion and exclusion criteria. Similar to the decision regarding how comprehensive the search should be, the decision to add an additional layer of inclusion-exclusion criteria is based on multiple factors. The first is the purpose of the search, which helps to dictate how comprehensive your collection should be. If the purpose is for patient rounds, then it may only be 1 or 2 articles that immediately confirm interprofessional decision-making. If the purpose is a class assignment, it may be important to make sure you pare down to only the best 3 to 5 articles based on need. Alternatively, if the focus is evidence synthesis, the collection will probably be much larger. Next time is definitely a factor. If there is an immediate turnaround, it may be more useful to provide a bigger collection and then have the requesters sort through them on their own. Or a much smaller collection based on the purpose of the search if time is not as much of a factor. Then, looking at the publication date of the most recent guideline, if one exists, can help to create specific publication date parameters. Because guidelines typically include systematic reviews, the recommendations contained within them are a summation of the literature up to that point. So excluding studies published before the guideline publication date might be useful to maximize similarities within your collection. Similarly, available evidence can help guide you towards potential exclusions. For example, if recent multiple systematic reviews or meta-analyses of RCTs exist on a topic, it may be useful to only include RCTs published since the most recent systematic review or meta-analysis. This process ensures that the RCTs that are part of your collection are not already accounted for in one of the higher level pre-appraised resources. Establishing inclusion and exclusion criteria is really a systematic process that helps you make objective decisions about what to include in critical appraisal. Objectivity is important because it helps limit unconscious biases that come along with deciding what to and not to include in decision making. Establishing inclusion and exclusion criteria also promotes transparency for why and how the articles that remain in collection are chosen. Finally, establishing inclusion and exclusion criteria helps maximize similarities between the articles that are in the final collection, which makes it easier to draw conclusions. You can't really determine what inclusion and exclusion criteria should be applied until you see what's in the collection to really determine the best way to apply an additional layer of decision making. So let's take a look at a few examples, and then we'll talk about how I went through applying different inclusion and exclusion criteria to our practice scenario. Typical exclusions at this point are usually related to study type, patient or problem related factors, or exclusions based on the available evidence. After looking at the titles and abstracts of the collection of 16 articles for our practice scenario, a few exclusions quickly emerged. For example, there were 2 studies that met study type exclusions. Despite applying PubMed filters, there was still 1 study protocol in our collection and 1 study that quantified burnout in ICU nurses, but did not include a mindfulness intervention. Next, there were 2 articles where the population of study included nursing students or midwives. Since our population of focus was hospital nurses, excluding those studies would maximize similarities between those that remained in our collection. We did not need to apply the available evidence exclusion to this specific collection, but there would be times where it might be useful to exclude RCTs that were published, to exclude RCTs that were published before the most recent guideline or meta-analysis. Next would be inclusion criteria. So typical inclusion criteria would be things like study setting or specifics about the intervention. In our particular example, we didn't need to apply study setting inclusions, but good examples would be hospital location and country where the study took place. Country can be especially useful as an inclusion criteria in cases of quality improvement topics, where nationalized healthcare models could impact findings or the application of results. In those cases, applying an inclusion criteria that only targets research conducted in the United States might be useful. For studies about medications, it might also be useful to match the dose, route, or even frequency of a therapy to your PICO question as closely as possible. In looking at our practice scenario, we did apply inclusion criteria that focused on mindfulness interventions specifically. This resulted in the removal of an article that focused on relaxation response as an intervention, which is closely related but not synonymous with mindfulness interventions. And this is really where background research can be critical, because during our background research, we uncovered an article from the Harvard Gazette published in 2018 that specifically discussed the differences between how mindfulness meditation and relaxation response impact the brain differently. So as you can see here, after applying our inclusion and exclusion criteria, there were 10 articles left in our collection. So now that we have our final collection of best articles, we're ready to move to step 3 of the EBP process, which is appraising the evidence that remains in our collection. It's important to use a critical eye when reading research articles. That's because the level of confidence you can put into any single study's results are tied to 2 types of error. Random error acknowledges that there is always some chance that a study's findings are at least somewhat due to chance. We'll talk more about this type of error later in this webinar as we discuss p-values. The second type of error is systematic error. This is the type of error directly related to how well a study was designed. Ideally, research study protocols are used to reduce sources of bias, which are due to human influence. As we've learned already, the top of the evidence pyramid includes clinical practice guidelines. Clinical practice guidelines are recommendations on how to diagnose and treat a specific medical condition. They help guide what to do or not to do in clinical practice in a very specific way. Good clinical practice guidelines are developed by clinical experts in conjunction with systematic reviews, evaluation of resource allocation, and patient values and preferences. According to the Institute of Medicine, now called the National Academy of Medicine, there are 8 key factors to look for when assessing the trustworthiness of a guideline. Transparency, which is related to how much detail guideline issuers provide on exactly how the guideline was developed. Conflict of interest, which relates to the expert group developing the guideline and other interests they may have. Assessment of the development group itself. For example, is it a single specialty or multiple specialties? Whether or not a systematic review was part of the development process. Whether the supporting evidence for each recommendation was stated and the level of evidence was assigned. Whether the recommendations were actionable, supported by evidence, and graded for strength of evidence. Whether the final recommendations were reviewed by external groups before publication. And finally, whether the guideline is current and whether there was a plan for when to update it. The next step down is systematic reviews and meta-analyses. The purpose of a systematic review is to summarize the results of multiple well-designed studies and provide an unbiased source of high-level evidence for decision-making. As you can see here, systematic reviews, as you can see, there is a very specific process for developing systematic reviews. So you're kind of taking this, identifying a question, and you're establishing a protocol, performing your search, doing a quality assessment, and if possible, then extracting data and pooling it. So there are 2 types of synthesis included in systematic reviews. You have qualitative synthesis and you have quantitative synthesis. Qualitative synthesis includes comparing studies in a narrative format using a series of expert judgments. Similar to this Venn diagram that compares apples and oranges, qualitative synthesis focuses on both the similarities and the differences in the available studies on a specific topic. Quantitative synthesis comes into play when the studies are similar enough that they can be pooled and analyzed together into what's called a meta-analysis. The diagram you see on the right is called is called a forest plot, and it's a visual representation of the results of pooling the data from multiple studies together. One of the most common resources for free comprehensive critical appraisal tools is the Center for Evidence-Based Medicine at Oxford University in the UK. They don't require your being a critical appraisal expert and are actually really easy to use. So while in the interest of time, we're not going to show an example of a systematic review, critical appraisal, you can see that there are systematic review critical appraisal sheets available. The great thing about the Center for Evidence-Based Medicine tools is that they're available in multiple languages as well, which is really fantastic. As we continue down the evidence pyramid, next we reach primary studies. There are two main types of primary research studies in humans. They're experimental and observational. In an experimental study, the purpose is to intervene in a specific way, usually a therapy of some kind, with a group of people and then compare findings to a similar group that didn't receive the therapy. In observational research, the purpose is to watch a group of people over a specific period of time and describe what happens to them. Experimental studies in humans are also called clinical trials. There's always an intervention involved in experimental studies. The gold standard for experimental studies is a randomized controlled trial, or an RCT. RCTs are designed specifically to minimize bias in the results. However, sometimes randomization is not possible for ethical or logistical reasons. So in those studies, they're typically deemed quasi-experimental. When appraising research articles, it's important to ask two questions. Are the results valid? And are the results important? And those Center for EBM tools walk you through that process step by step. And we're going to look at an example here in a second. Really, the goal of assessing validity of a research study is to understand the level of confidence you can place in the study's findings, because the study was sound and avoided systematic error or bias as best possible. The goal of assessing the importance of a research study is to determine whether the study's results showed any important differences between groups or relationships between things, especially if the results are statistically significant. The good thing is that research studies typically follow a roadmap. This allows us to find certain items in certain spots almost every time. So the abstract is always going to provide you information about the purpose and the study design. The methods section is going to give you, among other things, design details and sample size. The results will then give you both descriptive and inferential statistics, which are that statistical significance we keep talking about. And then the discussion is really going to focus on strengths and limitations of the article, as well as kind of tie everything together into a narrative conclusion. So the best way to show you how to use a research study roadmap is to show you an example. This is one of the RCTs that's in the final collection on the impact of mindfulness interventions on burnout in hospital nurses. What type of study is this? This is a multi-center randomized controlled trial. So let's go to the Center for Evidence-Based Medicine and really start to use the tool developed for assessing randomized controlled trials. So as you can see here, the first question in their appraisal tool is, was the assignment of patients to treatments randomized? To help us answer that question, there's a screenshot from here's a screenshot from the article's methods section about trial design. So we can confirm that this is a randomized trial. And then to take it a step further, the procedures section gives details about that randomization procedure. So minimization, which they talk about using a minimization method. Minimization is a dynamic randomization algorithm that's really designed to minimize imbalances between treatments, taking stratification factors into account. So they really did not just a simple randomization, but they did a complex randomization in this study. The next question in the RCT critical appraisal tool is, were the groups similar at the start of the trial? So next we want to look at the similarity between these two groups at baseline. In an RCT, one of the landmarks within the research study roadmap is Table 1, which gives you the characteristics of patients at baseline for overall, as well as for each arm of the trial. And then as you can see here, the authors also note in the results section that they didn't find any clinically significant differences between the two groups. So we can say, based on the information from this research study roadmap, that they were similar at the beginning of the trial. Next up is, aside from the allocated treatment, were the groups treated equally? To assess the equality of treatment between the groups, you'll really want to look at the details of the intervention, which live in the methods section of the research study roadmap. This section provides clues about how study staff maintain similarities in treatments outside of the intervention being studied, because both the intervention and the control in this particular study were offered during the workday to nurses, and nurses worked on different units and also multiple hospitals. The only item that study staff could maintain was preventing the control group from receiving mindfulness training on the job. So we're still kind of unsure about whether or not they were able to maintain treatment equally, right? And in reading this section, we're also learning that there's a published study protocol. So if we go to that published study protocol and look at it, figure 1 within that protocol provides additional insight about the study groups, as you can see here. But does this information help us know whether the control group was prevented from seeking out mindfulness programs on their own time? Not really. So it doesn't tell us. So we're left unsure about whether they were treated equally, other than the intervention, because they weren't able to control for those factors. Next is, were all the patients who entered the trial accounted for? And were they analyzed in the groups to which they were randomized? The purpose here is to determine whether the results included what's called an intent to treat analysis. An intent to treat analysis preserves randomization by including dropouts from both the intervention and control groups of a study as treatment failures. So the results section, so now we're on to looking at a different section of the research roadmap. The research roadmap, now we're to the point where we're really looking at the results section. So the results section provides the needed information to answer this question. So they state that 92.5% of the intervention and 100% of the control groups completed the 26-week assessment. And if we look at this flow chart, which is also in the results section, it's another landmark that can be used to answer this question. It's really kind of hard to see, but down at the bottom under analysis, it says that the primary analysis did include 40 participants from the control group, 40 participants from the intervention group. So they did use intent to treat analysis. So that really can help us confirm that, yes, everyone that entered the trial was accounted for, and that everyone was analyzed in the groups in which they were randomized. So our next question from the appraisal tool is, were measures objective, or were the patients and clinicians kept blind from which treatment was received? So let's take a look. Again, we're back into our methods section. The trial design info in the methods section gives us clues about blinding. So we need to think about this here. If the interventions were mindfulness-based stress management programming and a psychoeducational leaflet, is there even any possibility of blinding people from their assignment group? The answer is no. So in this particular question, we have to acknowledge that there was not blinding. They did use objective measures. They used the same types of questionnaires to assess burnout, but they were not able to account for blinding. And then finally, the last question in the appraisal tool is, what were the results? So as you can see here, that objective tool that I mentioned just a second ago, the hospital anxiety and depression scale, those scores decreased for both groups between baseline and 26 weeks. The mindfulness group, as you can see here, did have more of a reduction, but the differences were not statistically significant. Another small thing to note is that the sample sizes were very tiny in this group, in this study, 40 people in each group. So differences between the groups would have had to been very large to detect statistically significant differences. So if the study had been larger, there may have been a statistically significant impact. It really just kind of warrants the idea of expanding future research on this particular topic. So before we move on to kind of talking about the next steps on the process of EDP, I did want to just acknowledge that there are studies that we're not going to be addressing in detail today, and those are observational studies. So just to introduce what those types of studies are, a cross-sectional study is really data collected from a large group of people during a specific snapshot in time. Cohort studies observe what happens to a group of people over a period of time, sometimes even decades. Case control studies are used to evaluate very rare or emerging disorders and those with long times between exposure and outcomes. They're used to compare long-term exposures in a group with a specific outcome and match them to people without that specific outcome, and then see what the exposures were backward in time. Case reports and case series are used to provide very detailed descriptions of clinical courses of a patient or a small group of patients with a specific disease or set of symptoms to try and understand what's going on. And each of these types of studies has its own advantages and disadvantages. And the main thing I did want to point out today is that they have very specific timelines and ways of collecting data. So observational studies, are based on collecting data at different points of time. And because of that, as you can see here, cross-sectional studies occur at any point in time. And they're collecting very specific data using very specific forms and very specific protocols, but it's a one-time deal. Cohorts can either be prospective, meaning the data is collected moving forward in time, or retrospective, meaning the data is collected from previous documentation or by asking questions about what happened already. So in retrospective studies, like those circled here, You're really reliant on chart audits and self-report questionnaires from people. So those are, there's lots of opportunity for there to be missing data points or issues with what's called recall. So being able to remember what happened accurately. Case control studies are always done retrospectively, and data is gathered from medical records and extracted from physician notes. The key difference between retrospective cohorts and case control studies is that for case control studies, the investigator splits individuals by disease status, so that outcome. Whereas in retrospective cohorts, investigators split study individuals by their exposure status. So from a data collection standpoint, there are advantages to prospective studies because data can be collected, as you can see here, can be collected in ways that are very similar to experimental studies using data collection forms, specific study protocols. So that's why when you look at an evidence pyramid, those prospective studies are going to be higher on the pyramid. So the Center for EBM has multiple tools for appraising observational studies and appraisal tools for diagnosis, prognosis, and even qualitative studies like focus groups and structured interviews can be used. An alternative tool for appraising observational research is the Newcastle-Ottawa scale. This is a tool specifically for appraising cohort studies that assesses 3 domains using a star-based system. So providing stars, a star-based system based on selection criteria, comparability questions, and then outcome. And Newcastle-Ottawa scale also has a specific tool for appraising case control studies that uses a similar format. So now that we've talked at length about tools to appraise whether the results of a study are valid, I wanted to quickly hit on a few key points for assessing whether a study's results are important. While there are many ways that statistics are assessed and interpreted in research articles, one of the most common is a p-value. And p-values are used to indicate how mathematically significant differences, whether they exist between groups or how whether they show a relationship between 2 things. So when evaluating p-values, you're really focused on a threshold of p is less than 0.05. Just like in a middle school science project, the goal of research is to test a hypothesis. P-values help us decide likelihood that we are wrong if we say the result is due to anything other than chance. Small p-values help us not be wrong. So a p-value of 0.05 tells us there's a less than 5% chance that the reported results are due to chance. If the outcome of interest in a study is more serious, like death, you may only be willing to be wrong 1 time out of 100, or even 1 time out of 1,000. So in these cases, the p-value threshold would be much smaller than 0.05. And here you see a couple examples of how someone might explain the significance of a p-value that's less than 0.05. So that there's a less than 5% chance of incorrectly rejecting the null hypothesis. That's very 8th grade science fair project. But if we're thinking about it more in relationship to how we'd explain it in real world, it'd be like that there's a 95% chance that the difference between groups or relationships between things in a study would occur again if the study was repeated. So kind of taking that 0.05 and focusing on the inverse. So Okay, we've reached the point where we're ready to move from appraising the evidence to applying it. While during today's session, we've only looked at one RCT, and we found that there was no significant impact for a mindfulness intervention in that one study. Overall, our body of literature did indicate that mindfulness interventions do decrease burnout in hospital nurses. So keep in mind, this is something that we actually undertook as a project for our hospital system. And so we looked at the other 9 articles, all those systematic reviews and meta-analyses that came out of this process. And so therefore, our practice recommendation was that implementing mindfulness programs for frontline nurses is an effective strategy for decreasing burnout. As we mentioned previously, this practice scenario was an actual clinical request. So as a result of our practice recommendation from the literature, our shared governance groups worked with others within our organization to implement the Mindfulness at Work platform in our employee health education system called Imagine You. Last but not least, the final step of EBP is assessing the results. So a big part of assessing the results of an evidence-based program is quality metrics. According to the Donabedian model for quality of care that you see here, there are 3 key types of quality metrics: structure, process, and outcome. Structure metrics are related to the physical and organizational characteristics where healthcare occurs. So an example from our practice scenario would be the development of those Imagine You modules. Process metrics focus on the care that's delivered. So in this particular case, the services were delivered to nurses, not patients. But a good process metric would be the number of nurses who accessed the Imagine You models. Finally, outcome metrics include those that highlight the effect of the intervention. So in our practice scenario, a good outcome metric might be decreases in job call out and nursing call outs, and then also nursing turnover rates. So we really hope that this practice scenario has been useful in walking you through all of the steps of EBP and gives you the tools and resources you need to start applying them in your practice. So here are our references, and wanted to open for questions. And Emily, because of the way my screen is set up, I don't know if you would be able to feed me questions, because I can't necessarily close out the presentation.
Okay, so I will read you the first question. How does the Center for EBM checklist compare to those listed in CASP? So it's basically, like there's so many different like critical appraisal checklists for each study design. So why and how do you decide which one to use?
That is a great question. It's interesting because we use different checklists for different purposes. And so the one thing I like about the Center for EBM is it's very accessible from a health literacy standpoint, from the point of not needing to be an expert in understanding the biases and backgrounds to be able to answer the questions. They're very straightforward tools, so they're very easy to use for novices. When it comes to other tools, we sometimes focus on the questions from CASP. Sometimes we, for our day-to-day work in the Value Institute, we have kind of taken a more comprehensive approach, and we have created our own tools that are more specific to items from the Cochrane Risk of Bias tool and the Newcastle Ottawa scale, and applied them directly into our work. But it really is just a function of knowing your audience, who is your audience, what's the best way to kind of give them a tool that is accessible and easy to use. In general, I would say that all of the tools out there get to the kind of the heart of critical appraisal. It's really a function of how deep or how shallow your needs are for critical appraisal.
Okay, thank you. The next question is, can you please talk about statistical significance versus clinical significance?
Absolutely. And so I kind of hit on it a little bit in this when we were going through this randomized controlled trial, when I spoke about how if the number of participants was bigger, there may have been a statistically significant difference, because when a sample size is small, you need really big differences between the control and intervention for there to be a mathematical difference, which is the statistically significant difference. But that does not mean that there's not a clinically significant difference. So for example, we just did a lot of work with a group at our institution, and the focus was in sickle cell patients. Well, sickle cell patients are hard to enroll into studies for various reasons. And so sample sizes are relatively small most of the time. And because of that, statistical significance is hard to reach unless there is something that works really, really well. And so when you're looking at results, you really need to focus on not so much the p-value, but what are the actual raw number differences between the two groups if there's not a statistically significant difference, so that as a group you can look at it and say, are the improvements strong enough clinically to warrant potentially using this intervention in our patients or no. And a lot of it is related to whether or not there is, that the sample size will dictate a lot of that. And in the inverse, if you have a huge sample size, you're going to be able to detect all kinds of statistically significant changes that might not be clinically relevant at all. So it kind of works in both directions.
Okay, excellent. I don't see any other questions in the chat. There are some comments, but I would encourage everyone, since we have probably about 5 minutes left, if there's any other questions that you have, please put them in the chat right now and we can answer them. Or if you have comments for everyone, put those in the chat as well. Okay, we got one more question. What are some of the challenges? What are some of the challenges in critically appraising qualitative studies?
That is a very good question. So in my experience, one of the biggest challenges in critically appraising qualitative studies is really related to more from a results perspective than it is from a study design perspective. And I say that mainly because as I have been in this job for the past 7 years, I've seen the transparency improve vastly as it relates to the methods sections of qualitative studies. Qualitative studies now are much better at explaining how they set up the study to ensure that the questions were asked the same to each person, and that within the focus group perspective, that the facilitator stuck to the facilitator guide and things like that. So really a lot more of the issue then becomes, how do I take these qualitative results and provide them in a thematic way that makes it useful for the end user? But I would say that up until the last 4 or 5 years, it was also really hard to appraise qualitative research because they didn't provide the level of detail to make it easy. But I've noticed it's gotten easier.
Thank you. Okay, so the next question, can you address consideration of adverse effects or harm of intervention in appraising and applying results?
Absolutely. So that's not something it's something you collect as an outcome when you're appraising from a results perspective. So if that, when you're looking at a particular intervention, you want to look at the pros and the cons. So you're looking at how well did it work? And then what were the adverse events? And how serious were they? And how common were they? And so when you're looking at a body of literature and you can collect both sides, then once you have that information compiled, it then becomes kind of positioning those two things side by side in the context of facilitating conversation with your clinical team that you're working with. But it definitely really plays more into the application perspective. You need to collect that information as you are appraising, so that you have both sides of the coin, and then just making sure that you present both sides in conjunction with each other to the team or individual that's going to be applying the clinical context.
Thank you. There are no other new questions in the chat. So I don't know, we maybe wait 30 seconds, see if anyone has a last lingering question before we conclude the session. And as Deborah mentioned in the chat as well, all registered participants will receive the recording and the slides. Last call for questions. Okay, Amanda, I don't think we have any other questions.
Awesome. Does Deborah need to hop back?
Thanks for watching. This video was produced by the network of the National Library of Medicine. Select the circular channel icon to subscribe to our channel, or select a video thumbnail to watch another video from the channel.